Bismillah ar-Rahman ar-Rahim. Today, inshallah, we'll deal with hypertension as a case scenario. Our objectives will be definition of hypertension, knowing the grades of hypertension, risk assessment of patients, diagnosis of hypertension-mediated organ damage, and management of hypertension. We'll start with Mr. M. He is our patient for today. He is 56 years old. He is a male patient who is not known to be diabetic or hypertensive. He is a current smoker of 10 cigarettes per day for the last 20 years, and he is married with 4 offsprings. He is not using any chronic medications. He was not exposed to any procedure or operations before, and his father died of stroke when he was 65 years old. He has been complaining of shortness of breath for the last 6 months. His dyspnea proved to be NIHA class 2. He also complains of unexplained headache from time to time, frequent urination, especially at bedtime, with no chest pain, no palpitation, or syncope. The patient is alert and fully conscious with no special attitude in bed. He shows no pallor, no cyanosis. He is obese. His body mass index is 35. He has a large waist of 124 centimeters. He shows no organomegaly, no lower limb edema, but shows diffuse consternating crepitations all over the chest. The vitals were measured in the emergency room. His blood pressure was 160/100 on the right arm. His pulse is 80 per minute, regular, high force and average volume, no special character, equal on both sides, and the dorsal speed is felt bilaterally. His respiratory rate is 16 per minute, thoracoabdominal. His temperature is 36.7 degrees centigrade. So, what is the next step in the management? Should we go for local exam? Send the patient for chest x-ray, confirm the diagnosis of hypertension, or send for blood tests? What should we do? Of course, we should confirm hypertension first. How should we confirm? Be careful, the patient's blood pressure was measured in the ER. And you know the ER. ER is noisy, is crowded, is full of different procedures. So definitely measurement of blood pressure in the ER is a stressful condition. So we should allow the patient to rest for 5 minutes in a quiet place, and we should let him sit on a chair with his back supported and his legs on the ground, and then we measure the blood pressure. The exact method of measuring blood pressure was mentioned here in the European Society of Cardiology 2018 guidelines to measure blood pressure. And if you want to see, there is a link for YouTube videos to show you how to properly measure blood pressure. So we put the patient in a dark, quiet room, and we measured his blood pressure. His blood pressure in the office was 150/95. So we should think again, is this considered hypertension or not? And if it is, what grade of hypertension it is? We go back again to the definition of blood pressure according to ESC 2018. The blood pressure at the office, if the systolic is above 140 and diastolic above 90, is considered hypertension. So our patient is hypertensive. What grade of hypertension is this? Well, we have the optimal, less than 120/80, the normal, the high normal, and the grade 1 hypertension, which is a systolic range from 140 to 159, and diastolic from 90 to 99. Be careful, we have here what's called isolated systolic hypertension. which shows high systolic blood pressure and low diastolic blood pressure. And this is very common in the elderly population. Suppose we have one reading goes with grade 1 hypertension and another reading goes with a grade 2 hypertension. For example, 170 over 95. What grade should we consider? We should consider the higher one. So this patient 170 over 95 will have a grade 2 hypertension. Okay, so this is grade 1 hypertension. Could it be white coat hypertension? Is it possible? Yes, it's very possible. We know that white coat hypertension, every time the patient goes to the hospital or to the doctor's office, will have high blood pressure, and at home and during sleep, his blood pressure is normal. This is a kind of stress. And we can confirm this by ambulatory blood pressure monitoring or by home blood pressure monitoring. So, do you think our patient at this point in need of ambulatory blood pressure monitoring? He's still in your office. So, what is next? What should we do for him next? We go for local exam, send for chest x-ray, confirm hypertension by ambulatory blood pressure monitoring, send for blood test, make an ECG or echo for the patient. The patient is still in your office. What should we do? Yes, we should make the patient lie down and have a local exam. Because once we have a local exam, we may have some signs which will lead you to a certain place, or also may not make lots of lab investigations necessary. So physical exam is very essential for the patient. Okay, during auscultation at his apex, we find a normal first and second heart sound. There was an audible forced heart sound. There were no added sounds, no murmurs, and other areas of the auscultation are unremarkable. So here we have an audible S4. We go back again and think about what about the heart sounds. We know the first heart sound is normally found. It is due to closure of the AV valves. The second heart sound is normally found. It is due to closure of the semilunar valves. S3 should not be auscultated normally due to rapid flow of blood from the atria to the ventricles, usually in hyperdynamic conditions or in heart failure. And S4, you should not be auscultated normally except in conditions where there is vigorous atrial contraction. Vigorous atrial contraction happens due to lots of reasons. One of them is due to high left ventricular end diastolic pressure that may be caused by left ventricular hypertrophy or many other reasons. So I have a pathology here. This pathology needs to be confirmed. Okay, so what should we go for next? Send the patient for chest x-ray, send for blood tests, apply Holter monitoring for him, make an ECG or an echo for this patient. We go for ECG or AKG. This is electrocardiography. Okay, here in this ECG, the patient is still in sinus rhythm. Okay, and you know the normal QRS complex is a QRST. Here we find in V2 the S wave is very large. If we add it to the S wave in V5, we'll have more than 35 millimeter, what we call Sokolov index. It indicates increased voltage of the left ventricle. Increased voltage of the left ventricle happens due to two. At first, we have to exclude physiological causes like thin chest wall. Okay, and of course, our patient is obese with a large BMI, so he's not thin. The second thing, this voltage criteria is due to either two things: left ventricular hypertrophy, increase in the thickness of the wall, or left ventricular dilatation, increased in the left ventricular diameters. And here we have that it's recommended to have a 12-lead ECG for the patients diagnosed with hypertension to diagnose left ventricular hypertrophy. So, how can we distinguish hypertrophy from dilatation? What's our next step? Our next step should be echocardiography. Here in the echo, this is what's called the apical four-chamber view. This is the two atria, left and right, and this is the two ventricles, left and right. We can see the wall of the left ventricle showing a very thick and very hypertrophied walls. If you want exactly to have the measurements, we can have M mode and we can exactly measure the left ventricle, IVS septum and posterior wall, and even the diameters. We know the exact number. So now we know that this patient of ours having left ventricular hypertrophy. Okay, what investigation should we request for this patient? This is the recommended blood tests we should ask for our hypertensive patients. We should ask for CBC, complete blood count, fasting blood glucose, lipid profile, serum electrolytes, uric acid, serum creatinine, blood liver function test, urine analysis for proteinuria, and of course we already made the ECG. So we send our patient for this, and here are the results of his lab tests. His fasting blood sugar is 230 mg/cent. He's definitely diabetic. Remember the frequency in urination at night? His serum uric acid is 10 mg/cent. His total cholesterol 280, LDL 188, triglycerides 45, HDL 25. Definitely he is dyslipidemic. And the rest of his blood lab tests are unremarkable. Now, are we ready to form our impression about this patient? Yes, we almost have everything for this patient. So this is a male patient, middle-aged, smoker with positive family history of coronary artery disease. He is hypertensive, diabetic, dyslipidemic, and hyperuricemic. This is our impression of the patient. Once we have the impression, we have to form a plan for management. So, what's our plan of management for this patient? At first, we should go for risk assessment. Is this a patient with low, intermediate, high, or very high risk? And this is very essential because step 2, how to treat this hypertension and what target we reach depends on the risk assessment. And we should go for treatment of comorbidities. We should treat his diabetes, his dyslipidemia, according to the current guidelines. And we should improve all of this, 1, 2, 3 steps should go for the improved prognosis. Improved prognosis means we should choose the drugs and the procedures which had been proved by clinical trials to reduce mortality and cardiovascular events. Okay, so let's go for the most important step here, which is the risk assessment. How should we risk assess our patient? We know that there is some criteria. If they are present, then this patient is risky. Like what? Like men are riskier than women. Age, smoking, lipid profile, or dyslipidemia, hyperuricemia, presence of diabetes, presence of obesity, family history, early onset menopause in ladies, sedentary lifestyle, psychosocial and socioeconomic factors, and if the heart rate of the patient exceeds 80 beats per minute. So any of these criteria is if present, that makes our patients risky. What else? Well, If we have hypertension-mediated organ damage, which is complications of hypertension, this is a high-risk patient. There are some asymptomatic organ damage we should search for, like arterial stiffness, like presence of LVH either by the ECG or by the echo, presence of microalbuminuria, presence of renal impairment, is the ankle brachial index is low, less than 0.9, and if there is advanced retinopathies, hemorrhage, or exudates, or even papilledema. How about the symptomatic organ damage? Once we have a symptomatic organ damage, that means this is not only high, this is a very high risk patient. Like if we have a patient already have a stroke, have cerebral hemorrhage or TIA, if the patient have myocardial infarction or had a myocardial revascularization procedure before, like he had a PCI or cabbage operation, presence of plaques, proved plaques by imaging, like a patient has CT angio, coronary angio, or he goes for coronary angio, or even presence of plaque in carotid duplex. The patient is in heart failure or have a peripheral arterial disease or in atrial fibrillation. All of this, the patient is considered having a symptomatic organ damage and is considered high-risk patient. Who appears normal, who don't meet any of the previous criteria. We have what's called a risk score system. This is chart that depends on gender, either men, women, or men, if they are smoking or non-smoking, about the level of their blood pressure, about their age, and about the non-HDL level of non-HDL cholesterol. This is risk score system 2. Risk score system 1 used to have the total cholesterol instead of the non-HDL cholesterol. So you can use any of them. And know that these charts are different from a country to another. Countries also had been classified to low, intermediate, high, and very high risk countries. Unfortunately, Egypt and the Gulf countries, most of the Middle East, except Israel, of course, are considered to be in a very high risk countries. Okay. So what this risk score system will tell us? This risk score system will tell us the 10 years risk of fatal and non-fatal cardiovascular risk in the patients. We have a number for this score system, and this number we will use. So we risk assess by using all of these. Now we come to the conclusion. What is the conclusion? Is a very high risk, moderate risk, and low risk. A very high risk patient, as I told you before, in a patient with an already documented cardiovascular disease, or in a patient with an imaging evidence of atherosclerotic plaque, or in a patient who is diabetic and showing target organ damage due to diabetes, in a patient with severe renal impairment in which glomerular filtration rate is less than 30, or in a calculated risk score more than 10. If the patient met any of these criteria, then he is in a very high risk category. How about the high risk? High risk in a patient with a marked elevation of a single risk factor. For a patient showing total cholesterol more than 310 milligram percent, or in a patient with hypertension at grade 3 more than 180 over 110 is considered high risk. Or a patient with diabetes, all patients with diabetes mellitus who don't show end organ damage, or a patient showing LVH, remember our patient, or a patient with moderate renal impairment, or a calculated risk score from 5 to 10. Also, we have moderate risk and low risk. So we should go for this table, but after knowing all the other criteria for documentation. Okay, now Mr. M, our patient, is at very high risk, intermediate risk, or low risk. What do you think, Mr. M? Of course, Mr. M is at a high risk population. Remember, I told you risk assessment will give us how to proceed with the next step in our plan. How to manage a high risk patient with hypertension. Again, we go back for the ESC 2018. What they are telling us: all patients with all grades of hypertension should go for lifestyle modification or lifestyle advice. Our patient is grade 1, right? Then we use this column. What is this column telling us? Immediate drug treatment in high or very high risk patient with cerebrovascular disease, renal disease, or with hypertension mediated organ damage. Our patient, as we stratify him, was high risk. So we should go for lifestyle modification and immediate drug treatment. How about those patients who are in low or intermediate risk? We can give them lifestyle modification and give them a chance from 3 to 6 months and then follow them again. If the blood pressure is controlled, good, continue with the lifestyle modification. If not, then we should start medical treatment. Okay, so we should ask our patient for lifestyle modification and we should prescribe medicine for him. Okay, so what's the target of the blood pressure we should reach in this patient? Again, the targets depend on what? Depend on the age of the patient and depends on the comorbidities of the patient. So our patient was what? 55 years old? Then he is in this category. He is hypertensive, yes. He is diabetic, yes. Is he with renal impairment? No. With proved coronary artery disease? No. With cerebrovascular disease? No. Then we use this column. His target should go to 130 as systolic blood pressure. And if the patient is tolerating it well, we should go less than 130, provided that we never exceed 120 for systolic blood pressure. What do you mean if the patient is tolerating? Some people may be dizzy, may show signs of low perfusion. So in those patients, we should not go less than 130. How about the diastolic blood pressure? Diastolic blood pressure here should go less than 80, but not less than 70. Okay. In here in this column, look at the target. It's 130 for everyone, except for patients with CKD, chronic kidney disease. They should go less than 140. Why? Because clinical trials told us if we go down less than 140, the events and the mortality will increase in this patient. How about elderly population? Look at the 80, octogenarian, and from 65 to 70, target should go less than 140 to 130 if the patient is tolerating it well. Means we should not allow the patient to have low perfusion, especially in those patients, those octogenarian, because you know what happens? If the patient has postural hypotension, he will fall down, fracture neck femur, hospitalization, DVT, pulmonary embolism, and we have lots of controversies about those patients. And so just we can leave this patient at 150, 90 and 160, 80. It's okay, no problem. But we should consider tolerability of the patient if we give management for those age group. Okay, so right now we go for medical treatment, lifestyle modification. Our target should go to 130 and to 180 if the patient is tolerating it well. Okay, what medicine should we use for this patient? Okay, we have to make what's called tailoring therapy. Tailoring therapy in Arabic means نفصل العلاج. tailoring كان حاجة اسمها ترزي، tailor اسمه زمان ترزي أو dressmaker. الفستان اللي هيتعمل ليا غير الفستان اللي هيتعمل ليكي، غير البدلة اللي هتتعمل لك، صح؟ كل واحد different على حسب الميجرمنتس بتاعته. عشان كده احنا بنقولك في الأول ايه؟ ناخد history كويس قوي، نعمل exam كويس قوي علشان نعرف ايه ال compelling indication وايه ال compelling contra indication. يعني ايه compelling indication ويعني ايه compelling contra indication. Let's go first for the antihypertensive groups of medications. We have ACE inhibitors or ARBs. تمام؟ خلي بالك احنا قلنا ايه or يعني ايه؟ We should not combine both of them. Either one of them. Preferably we start with the ACE inhibitor. And if the patient had a complaint, usually it is dry cough, we should go for the ARBs, but never, never, never combine. The second group of drugs is the calcium channel blockers, the diuretics, the beta blockers, and the others, more commonly the alpha blockers. Okay? The first four groups have been proved to reduce blood pressure and reduce events and mortality. So they are known to improve prognosis in patients with hypertension. Beta blockers have proved to improve prognosis only in a special kind of population, heart failure and coronary artery disease, not in all patients with hypertension. There is some controversies about beta blockers, so just let's not talk about them. Okay, so what are the compelling indications of each of these drugs? We know in a patient with congestive heart failure, it's mandatory, it's compelling to give him ACE inhibitors or ARBs. It's compelling to give him a beta blocker. It's compelling to give him a diuretic and compelling to give him a potassium sparing diuretic like spironolactone, because all of these drugs had proved to improve survival in patients with heart failure. So we should apply these guidelines and give patients with hypertension and congestive heart failure these medications. In a patient with coronary artery disease, it's mandatory to give him a beta blocker. It's very important. ACE and calcium channel blocker is the third line. So we should start with the beta blocker and ACE inhibitors because according to the trials, clinical trials, these drugs will improve survival. In a patient with diabetes, it's mandatory to give him an ACE or ARBs because they show a renoprotective effect. In a pregnant lady, we should use labetalol for emergencies and long-acting nifedipine or methyl dopa or hydralazine for oral medication, because these drugs are considered safe in pregnant ladies. In black patients, in the elderly population, ACE inhibitors will not work in a good way. So we should start with diuretics and calcium channel blockers. Okay, these are the compelling indication. How about the compelling contraindication? Well, we know that diuretics, especially thiazide diuretics, will increase uric acid. So they are absolutely contraindication in cases of acute gout attacks. In a patient receiving beta blocker, we should not give it to him if the patient shows a reactive airway, like active asthma, or a patient showing high-grade heart block. Okay? In a patient with a calcium channel blockers, especially the verapamil and diltiazem, we should not give them to a patient with heart failure because they have a strong negative inotropic effects. ACE inhibitors and ARBs are absolutely contraindicated in pregnant ladies, for example. We should not, this is a crime. We should not give it to them. Okay? So, knowing the compelling indication and compelling contraindication for the drugs, What should Mr. M use? What we should give him? Okay, we should of course give him ACE or ARBs because he's diabetic and these drugs showing a renoprotective effect. And we should give him a calcium channel blockers if he is in need. I'll tell you later on how to use both of them. Should we give him diuretic? Well, his uric acid is 10. So we should not use it except if we have a compelling indication for a diuretic, like the patient shows pulmonary congestion or pulmonary edema. In this way, we should use a diuretic. So what can we do? The other thing is a beta blocker. Although the patient is not showing reactive airway, but remember the consonanting crepitation we heard during the auscultation of his chest. So we should be careful. But nowadays, we're having a very high selective beta blockers. And even the ASC guidelines said we can give bisoprolol, which is a very high selective beta blocker to a patient with COPD. So no problem. But anyway, we should start with ASO or ARBs and calcium channel blockers. Now we go again. Should we use a single or combination medication? We go again. Okay, we use one pill. We should start with one pill having two medicine or what you call a dual combination. In all patients, we should start with ACE or ARBs plus calcium channel blockers or a diuretic in all patients, except who we should use a single pill and a single medicine or a single drug in those patients with low or intermediate risk, or in those patients who are elderly or frail, in which we are afraid too much reduction of the blood pressure will lead to complication. So our patient, we start with a single pill and a dual combination of ACE or ARBs plus calcium channel blocker. Okay, we should know also there is a device-based treatment of hypertension. The most famous of them was the renal denervation, which is now obsolete because it did not show good results. We have carotid baroreceptor stimulation and induction of AV fistula. These two procedures are still under trial, but we are not using them anymore. Just have an idea about it. Okay. How about the lifestyle modification quickly? This is the Mediterranean diet in which we allow all of our patients to use. And what besides the diet? We should have salt restriction. We should restrict alcohol. We should go for body weight control, regular aerobic exercise, and smoking cessation. As you see, lifestyle modification, almost this is 80% of the treatment of hypertension. We should know it very well and take your time and speak to your patient about it. Okay, is it possible that our patient had secondary hypertension? Do you think he had secondary hypertension, our patient? Well, at first, we should go for a definition of resistant hypertension. What's a resistant hypertension? Hypertension is defined as resistant to treatment when the recommended treatment strategy fails to lower office blood pressure less than 149. So we give all the medical treatment, the well-tolerated maximum dose of our medication, and in spite of this, the blood pressure fails to go down less than 140/90. And we have to be sure that this patient is really having a resistant hypertension. Okay. Why? Because secondary hypertension is a part of resistant hypertension. So once we find blood pressure fails to go down with medical treatment, we should suspect secondary hypertension. The most common cause of secondary hypertension is obstructive sleep apnea, which is OSA, and renal parenchymal disease. These are some rare cases. The rarest case of them all is coarctation of the aorta, which is the most common cause of cerebral hemorrhage in the young, in children. Okay, just one more slide. Hypertensive emergencies versus urgencies. Hypertension emergency is a situation in which severe hypertension is present, associated with acute organ damage, and is often life-threatening and requires immediate but careful intervention to lower blood pressure. Usually we give intravenous therapy. So this patient needs hospitalization, starting intravenous medication, and management according to the organ damage which is shown in the patient. Hypertensive urgency is also grade 3 hypertension, but the patient is not showing hypertensive mediated organ damage. In this situation, some people may like to admit the patient to the hospital, but we give oral medication slowly. And now we have now advice to send the patient home and give him oral medication and follow up the patient in the outpatient department, but we have to be sure this patient is not showing organ damage. So in our conclusion, hypertension is a prevalent disease that increases morbidity and mortality. Careful history taking and examination are essential for proper management. Various lab tests and radiology needed for the assessment, and the choice of the proper drug needs careful and thorough assessment. Thank you and good luck.